had apologies from Karen Broughton, as the other member of the committee. That's all, I think, isn't it, Yvonne? We haven't had any others, have we?
That's correct, Sue.
Okay, and just to note that this meeting's going to be recorded and then uploaded onto the website. Next item, declarations of interest. You've all got the members' information. Is there any amendments or additions that anybody wants to add?
No.
No, fine, okay. There's also, for those who need it, and I often do, a glossary acronym buster on the website that the public can use if they don't understand. I think it needs adding to, actually. I think I've seen a few more acronyms arising over the last few months, so maybe we could add a few more. Okay, so the Chorusy is 3 of our 5 voting members on our terms of reference, and we have the 3 of us here today, so that's great. Minutes of the previous meeting, should we move on to those? Are we happy to approve those? Does anybody want to review or comment on them? Page. So if we just go through the pages of the minutes, the first page of the minutes, second, third, this could be dangerous, fourth, fifth, sixth, seventh and 8th. So we're all okay. We're happy to approve those as the minutes of the meeting of the 2nd of July. No, oh, John, you wanted to say something. You need to unmute yourself, John. You're still muted. Oh, that's it.
Okay, just a couple of points, if I may, Sue. At paragraph 7.2, it refers to the Kingston and Richmond Place and Borough committees. It would be helpful if we could just record actually that neither the Place nor the Borough committees are meeting at the moment. If that's okay, please. Because it implies that, it mentions that the Place committees aren't meeting and therefore implies that the Borough committee meetings are happening, but of course they're not at the moment. In paragraph 7.2?
Yes, yes. I just wanted to make sure that anybody else wanted to deny or confirm that. Because I think I don't think they're meeting in their legal form. I think there are meetings of people, but whether you'd call it the Borough Committee or it's a sort of network, because there isn't the delegation, that's what we're talking about, isn't it? So because the delegation hasn't taken place, the formal Borough Committees and Place Committees are not meeting. People do talk to each other and meet, but Tonya, did you want to add anything?
Just to confirm that, Susan, they're not formally constituted at the moment because of that reason. So that would be an accurate reflection in Kingston Richmond.
Okay, Lucy, did you want to add something?
Only for completeness that in Sutton they are meeting, although they don't have formal delegation.
Okay. Right. Okay.
Yes, that's a crucial point for Health Watch, as Tonya will know. So I just wanted to be, if that could be clarified, that would be helpful. And then one last point on page, I think it's page 12, Susan. There's a reference to more details to be circulated about plans for online patient consultations. Is there anything more that can be said on that, or is it somewhere else in the agenda?
Just remind me where that was.
I think it's in the end of paragraph 7 on page 12.
This could be brought back to the next Primary Care Commissioning Committee in relation to that, is it? Or?
Well, it said there's a reference there to plans for further discussions around the ongoing use of online patient consultation. More details to be circulated shortly.
Oh, right. Okay.
And that's what just wondering, yeah.
Jonathan, did you want to, or Andrew, did you want to comment on that? Andy?
Yeah, I can, thank you. So yes, they have. I think I'm hoping that there have been details shared and circulated. I think 1 or 2 meetings have taken place. Let me go back to the team though, John, and make sure obviously you and your colleagues are involved, but I would certainly hope you will be. And if not, you certainly will be. Okay, thanks very much. That's good. Thank you.
Are we happy then? Is that complete then? Very good. Right, so we've signed off the minutes. You've also had a report from me, which is actually just the report that went to the governing body. I think just to note that for information, I don't think there's anything material in that you weren't aware of. It's just a report of our discussions to date. So we can move on to our main agenda item. I'd like to welcome Nicola again here to walk us through, I think we're going to walk through the South West London approach to supporting primary care in quality assurance and improvement. And I think, hope you are there, Nicola. I'll just check.
Yeah, hello. Hi.
I don't know how you want to play this, whether you're going to project someone's going to project the
Well, everybody's
slides.
got the slides in their packs. I can actually, I might ask Andy to project it. It's easier if someone else does it while I'm talking.
That's a
actually.
good idea. Good plan.
To see you all
Andy
then if you're waving at me.
I might ask Yvonne if Yvonne can do it.
Sorry?
So if people have got their slides, then they could look at them on in their pack, can't they? But
we can project if we need to. So I'll start talking then, shall I? So we don't
yes,
waste.
that'd be great. Thank you, Nicola.
So I think we've got about 30 minutes for this agenda item. So Susan, if it's okay with you, I'll take the slides as read, but refer to them and talk for less than 10 minutes, flagging the important issues. But then we'll have plenty of time for discussion if that's all right. So general practice services are, I'm like a broken record, aren't I, really? They are of fundamental importance to the NHS and in South West London, important to us. So this committee will want to know that we have a service that is of high quality. And I'd go as far as to say that it's mission critical, because thousands of patients every year have several interactions with their practice, some of them on most days, and GPs and their practice workforce provide proactive care, unscheduled care, prevention programmes and a whole range of other services, and really importantly, continuity of care, which makes the system efficient and valued by patients. And if general practice doesn't work well, the rest of the system doesn't work well. So GPs, of course, are also direct commissioners of service in the sense that GPs at an individual level impact on how the CCG's budget is spent through the way that they prescribe, investigate and refer. So the impact of variation in quality of care in this regard can also be really significant. So we have as a committee a delegated responsibility since 2016 for monitoring quality and acting to address areas of concern. And it's not only therefore our duty, but really imperative for the CCG and the ICS to ensure that general practice is the best it can be, or as my 12-year-old would say, but understanding the various elements that combine to create a high quality service is not easy. It's a complex thing to do. So the South West London Quality Performance and Oversight Committee, QPOC, is currently looking at how we manage quality in our large CCG footprint, having merged the 6 local systems. And the discussions they're having about that generally also apply to general practice. So I hope this conversation can also contribute to that debate. How do we do this well? And of course, we've got quite a lot of overlap here between people on the QPOC committee and this committee. So hopefully we'll be able to take this conversation into that forum as well. So let me just look at, so if you look at slide 2, I'm just going to flip through the slides now, really, if I'll take people through them. So the 3 pillars of quality are described by Darcy, and they're safety, clinical effectiveness and patient experience. And this is widely used in the NHS as a way of describing the elements of quality. Slide 3 describes how each of those pillars is split into several elements that we use. But that's really simplifying it. The list is not exhaustive, and every individual section has more sub-elements. So it's just an extraction really of the big things that we look at. We have a quality assurance framework, and on slide 4 you'll see a link to that so you can enjoy the full document in all its glory. And it describes the systems we have in place and the governance around it. So that's where a lot of the detail is for this. Slide 5 describes our approach, which is the nub of this really, and it's born of years of experience through PCTs and then our constituent CCGs, which now make up the boroughs of South West London, who all had in place in their own system prior to merger ways of managing, of monitoring, of dealing with quality of care in general practice. So the approach is one which is evolving, but which we're describing as supportive, proactive and educational. And that approach enables practices to be the best they can be. We've got systems in place, a sort of an approach which provides guidance, information, data, benchmarking, tools, education, all that help practices to have a focus on their own quality of care, which can then be drawn into the local systems in boroughs, who then have oversight of it through the primary care quality groups. Now, boroughs were starting in different places with this, and the PCQGs were not in existence in every borough in the same form, and so they're either being established or strengthened at the moment. Each primary care quality group looks at the quality of commissioned services under the GMS and PMS contracts, but also of the locally commissioned contracts, and there are many of those. So a local approach is very much needed for that reason, but also because the level of detail that the PCQGs go into is really impressive, and each area is beginning to contribute to a dashboard that will help to bring all of this together. So the dashboard is in development, and it doesn't stand alone, of course. Local understanding of the history and the context is really key as well. The South West London training hubs are evolving, and some of those are really high performing already, and where there are quality concerns, addressing the issues through education can be really very effective. Supporting practices where quality concerns have been identified. Let me just see if you've got that. Yeah, the vulnerable practices one, the next one, Andy.
This one, yeah.
Where these quality concerns have been identified, this is described on this slide, and that programme's ongoing. We already had this vulnerable practices programme, but it's much broader than that really. Our local clinical leadership and primary care managers are absolutely key to it, and the practice support teams are in various incarnations in the different boroughs, but they essentially provide a means to reduce variation, resilience in a very facilitative way. So they visit, they provide information, feedback to practices on their own performance. They facilitate the discussions in practice meetings or with key individuals, and they help practices to identify their own issues and put in place plans to address them. So the next few slides I won't go through because they describe where each borough is in terms of their development, and I think that people will have different levels of interest in the different areas, so we won't go through those in detail, but I think we can probably answer questions on specific issues if you want to pick them out. So I think that Primary Care Committee, we need to have visibility of the quality of care across all of South West London general practice, and having a dashboard will really help us and also help QPOC, of course, but also what's needed and what is a sense of reality in each borough, which a dashboard doesn't fully reveal, so it's not the whole story really. So I'll be very interested to hear from committee members what you think about this approach and how you think that we can improve it. So Susan, I'll hand back to you now so that we can perhaps have a discussion.
Okay, I don't know whether there's any observations or input that any of the place leads want to add to your presentation, or who have we got? Nobody wants to add anything else. That's very helpful. Okay, so I'm going to. Sorry, who's that? I thought somebody was speaking then. Jonathan, did you want to pick up on anything first?
Thanks very much, Nicola. Thanks, Susan, as well. That was really helpful. I guess one of the interesting things is the primary care quality groups establish themselves in each borough, and of course they start from different places and come from different places, is perhaps to share some learning about what they've managed to achieve and what's worked really well in one place that we might want to replicate in other boroughs. So I guess my core question from Nicola's presentation is, how do we share some of the good things that are happening in one borough with the neighbours, and make sure collectively those groups are able to report back to this committee and to the Quality and Performance Oversight Committee in a way that gives us all collective confidence. So I guess that would be my question, to sort of prompt our place colleagues on their thoughts.
Les, do you want to ask a question, and then maybe people can reflect on both of them and then come back?
Well, I was wondering about, and in fact, what I was first going to say is, Nicola, I thought that set of slides was excellent, and actually it makes a very clear explanation of how you plan to move forward with this. And I think bringing the boroughs together and aligning it is going to be very useful. But there is clearly differences between the boroughs and what they require, and this allows those things to be explored by each borough, and I think that's really great. I really like that. I was quite interested. One of the things I was going to ask about was the SIs and how the interaction between primary care and the other providers is going to happen, because quite a lot of SIs involve both the trusts and GPs, and how we're going to take the learning forward from those as a whole.
Okay, I'm also interested in exploring, when people are reflecting on this, is that you mentioned it in part, Nicola, that this is just a snapshot of some of the data that would be looked at to sort of give an indication of quality. But you also mentioned about the way that general practice engages with its patients and the public, really, in shaping and getting self-management and self-care. And so it's not just about the communication and connection with local people, but the involvement of people in their own primary care. And I think we've talked about this before at other meetings about how we might help facilitate general practice to see their patients as the partners, really, in terms of shoring up the quality, making sure that the clinical effectiveness of what they're doing particularly is as good as it can be. So the three things, one about sharing, wasn't there, one about the links between general practice and the wider system, and the other about the partnership that we have with patients. So I'm going to go down the list with the hands raised first, and then we'll come back. Lucy, you had your hand up.
Yes, thank you, Susan. Thank you, Nicola. I also agree the slides are really good and ones we could use in lots of different forums. So to pick up Jonathan's point, I think Sutton had a primary care quality group, has had one in place for some time and been through that development curve. So very happy to share, I'm sure, the learning from that, and very pleased to take part in this next step of collaboration, because I'm sure there is some streamlining in the benchmarking that we can do across the South West London boroughs will be really valuable. Alongside that, we're also trying to map the sort of comprehensive quality approach for the Sutton place. And it's jolly complicated. I think we've got a QPOC focus session coming up on it. But when you map the different services and approaches through place and then up to different South West London CCG committees, I think we're going to have to go through several different iterations to check that we've got the right connections, so that we're seeing quality in the round. I think the way that the primary care stuff has developed is really, really good, because it's a fantastic in-depth, inward-looking focus on primary care. The bit that we're trying to do in parallel is make sure that we've got the connection across a place, so that we understand how it works with our deprived populations or the integrated services. And I think that last bit is becoming more important, given how core primary care is to our integrated service approach, through things like in Sutton Health and Care. And so where primary care is an integrated part of a care home team or a rapid response team or an ED team. It's trying to make sure that we've got an approach that is not just about it's practice based, but is about primary care and GP leadership inclusive as well. So I think we're in a really good place. It's a really good starting point, and I think as we go forward, we'll be looking at that bit about integration is going to be really important.
Okay, thank you. Catherine, did you want to say something?
Thank you. Yes, so I guess similar reflection to Lucy. So in Merton and Wandsworth, we've had an established approach to looking at quality through a primary care quality review group for quite some time now. I thought it might just be helpful. One of the things that we think has been particularly useful in that is our practice support team. So in each of the boroughs, we have a team made up of local clinicians, practice managers, GPs and practice nurses, who can proactively go out and support a practice with real hands-on stuff as and when we identify a quality issue, and then we have a range of other stakeholders that we can draw into that team as needed. So, you know, if there's an issue identified with the practice's interaction with how they work with care homes, we've got a lead that we can draw into that. Likewise with secondary care, we've got various people we can pull on who are really good at actually getting out into the practices, understanding the operational issues, and then working with them to try and resolve it. And we found that that's been far more successful than perhaps when we were trying to do this as a CCG team, because often we're just simply not the experts. So I think what I was going to reflect is that whilst there's absolutely learning that we should share across the boroughs, I think when it comes to that real operational, how do you get the improvement, that does need to be local teams, or that's what our local learning has showed anyway.
Thank you. Apologies if I get your pronunciation. Asia, is it?
Yeah, thank you, Chair. And so thanks for that great presentation, Nicola, and talking as a GP, but also as one of the medical directors that looks after Merton, Sutton and Wandsworth. We certainly have seen a demonstrable, measurable difference in the work that's happening on the ground. My question really, in terms of your sense of reality, point for discussion, Nicola, and moving things forward, when we look at the definition of quality in the domains that you've mentioned from Darcy's definition, we look at it in the sense of the triple aim, you know, driving value, improving outcomes and patient experience. But increasingly, we're now shifting from that triple aim into the quadruple aim, as you're aware of, around physician and staff wellness. And what's strikingly clear is as our staff are trying to deliver what's expected of them to drive quality, they're doing it at detriment to themselves. So we're seeing burnout increase, we're seeing a lot of anxiety and low mood, and as a consequence of that, clinical safety is at risk, because you can't tend to look after people if you're not well yourself, or the evidence shows people will miss those safety alerts, etc. So I'm just really wanting to know, what is the strategy for taking that into account around the physician, or maybe perhaps team staff well-being and wellness, because that hasn't been measured anywhere in the documentation that's been shared. But I think it certainly is pivotal, given that we have a workforce crisis. Most of our doctors are burnt out. In particular, COVID has demonstrated that, even though general practice has been remarkably well at delivering. So, excuse me. So that's just my thoughts and concerns, and just a question there around: is there an opportunity to bring something real and tangible to really create that sense of reality, where we're not just doing a survey, but we can track and then see where our staff are in relation to the quality as quality improves as well, because I think they go hand in glove together.
Okay, I won't ask you to answer that just yet, because I realised that I didn't ask Mark. He had his hand up, wanted to make a comment. Mark, did you want to?
Thanks, Susan. Just to say that I just want to echo what Katie and Lucy have said around kind of the local challenges, but also the local opportunities. And actually in Croydon, we have a variation team as opposed to Katie's, but it's the same kind of focus of improvement and support to practices. I just wanted to pick up on the sharing across boroughs, because I think one of the things that COVID has given us is the primary care cell. It's given us the primary care clinical cell. And also we've re-established the Transforming Primary Care Delivery Group. And that really are mechanisms for us to share across boroughs and learn from each other. And you see that on a kind of daily basis with leads coming together and clinicians coming together. So, you know, it's not there in its entirety, but I think one of the things that COVID has given us is a kind of a freedom across boroughs to kind of learn from each other.
Okay, so Andy, you did have your hand up just now, but do you want to, is it yours more a comment, or is it to start answering some of the questions? So we've heard a bit about sharing, we've talked about the integration agenda, which is about links to other providers, but perhaps not in the context of SIs specifically, an issue on workforce and the issue of patient partnerships, really.
Yeah, so it's probably a little bit of all of those, actually. So I think that the one thing that's important to say is that primary care, as Assi rightly said, primary care quality doesn't stand still, really. It's not an island either. You know, there's so many things that impact it on a daily basis. And that's why I think the proactive and the really supportive and kind of that education approach is the right approach to take. I think it probably is worth saying, as Lucy said, as a baseline, as a benchmark, we're really good when it comes to quality and that core definition. But as you rightly points out, it's just kind of a point in time, and that COVID has changed things an awful lot. So it has, obviously, and maybe one of the things we bring back at the next committee, Susan, is just a bit of a deep dive into some of those support mechanisms that we're really working with practices, federations and PCNs on. I think that will hopefully give a bit more of a rounded picture of everything that we're trying to do and support practice with, so we can definitely do that. But I think there's been an awful lot of shared learning because of COVID, as Mark rightly says. So we're now seeing, I know we've got people who are perhaps previously supporting just Wandsworth that are now working across other boroughs as well, on some very detailed practice specific issues. I think that's a real positive, and I've seen a lot of engagement and collaboration over the last 12 months, and with Healthwatch colleagues as well at these local primary group meetings, and also the input of the LMC. I mean, it's been really valuable on a day-to-day basis. So I think it will get better, but I think we need to make sure that our sort of surveillance, if you like, is really heightened now more than ever. But I do think we've made great strides. And in terms of the SIs, again, I mean, we made real strides with Make a Difference alerts, so how we encourage and support practices to raise any concerns that they may have, and also vice versa with perhaps out of hospital or secondary care colleagues, and really trying to work with them on a collaborative approach. So we're trying to do a lot of work, I think, as the governing body talked about recently, around some of the outpatient work. So again, I think it's really now part of the moving from boroughs, recognising that a lot of that work happens there, but also seeing the benefits of the wider CCG and the wider ICS and some of those systems and opportunities. So I think, it is a constantly learning and evolving picture, and it never stays still. But I think we've got some really good foundations and some really good, very recent learning, and some of the developments that we've had that stand us in a really good place. But next time, I think we'll bring back a bit more of a deeper dive into some of the points that Asia raised, if that's all right.
Okay. Lucy, you've still got your hand up. Was that from a previous, or did you want to add something?
It's an old hand, I'll bring it down. Okay,
John, you wanted to ask a question.
Yes, I just wanted to pick up on some of the things that Andrew just said. We obviously we're very happy that Healthwatch is included in these borough arrangements. I'm not quite sure I'm cited on what's actually happening in Kingston and Richmond yet. No, I appreciate each of the boroughs is in a different place. If I've got this right, Andrew, there's a central, as it were, Southwest London level quality group that meetings together. So we're talking here about sharing information and all the rest of it, which is absolutely crucial. I accept that. But is there a formal structure for doing that at Southwest London, and is Healthwatch intend to be included in that? And so I don't waste your time too much, I was going to ask later if we could be a bit more cited on maybe what the training hubs are up to. But if you're going to do a deeper dive later into some of the support mechanisms, I can leave it until that point.
Okay. Do you want to answer that one then first, Andrew?
Yeah, so on the second point, John, yes, we'll absolutely include that in the more detailed update at the next meeting. I think into your first question, we don't have a central primary care quality group, as it were. But what we do have is very strong local groups, which, as you referenced, Kingston and Richmond, etc. So what we do, and I think the slides hopefully point out, we kind of have a generally speaking, a common and consistent approach for that. So that's to make sure that we've got the right frameworks in place about being proactive, being supportive, and similar sort of membership on those local groups. Because what we've found, as Katie said in Merton Wandsworth and Lucy in Sutton, is that local intelligence really helps you get better outcomes for the practice and for the patients. I think you went to a South West London group, and we do all of these. We talk on a daily basis, so we're always sharing and learning off one another, but it's not a formal set process. But again, what we've found and what we're really encouraging is that as long as we have sort of a consistent approach and definitions and ways of working, that we find that local, working with the local practice and the local clinical leads, really helps us to support practice to get the best improvements ultimately. I think Nicola was alluding to the sort of the oversight that brings together all the various performance and quality indicators across South West London, and obviously primary care is just an element of that.
Nicola, can I come back to you then, because picking up some of the other questions that perhaps we haven't explored in much detail, particularly the one around workforce. Is there any observations that you wanted to feedback on that?
Yeah, so I really welcome that comment from Asia. Actually, I think it's sort of very insightful but barn door obvious as well, if you see what I mean. So we've got to look after our people, and understanding how we're doing that contributes enormously to quality. I completely agree with that. I think there's a challenge for us in understanding what we do at local level and what we do at South West London level. And we've got a workforce work stream, which will be looking at all sorts of things from South West London level and local workforce initiatives as well. And you know, the primary care cell gets involved with workforce issues as well, with the, you know, the BAME risk assessments for staff and all that sort of thing. So it's sort of becoming, you know, ubiquitous in the system, which I think is good, but it does have to be drawn together somewhere. I'm not sure whether drawing it together at a local level will be terribly efficient, but I do think a lot of the issues are at a very local level. So it's how we do this. So I think this is perhaps a conversation for us, maybe in QPOC, to see how the information streams come together and see what the issues are, but also get local quality teams to consider what the issues are there, and let's work through that. You know, I think there's work to be done there, Asia. I think you're quite right. So yeah, so that's on that bit. Could I just comment, Susan, on your issue about patient participation? Because I was sort of thinking that there's loads of ways that you can, you know, involve people in all of these processes, and we've demonstrated some of them. But I wonder whether, I think quality issues are really good fodder for talking to patients about in very open conversations, and that we perhaps should be either doing it at South West London or providing material at a local level, so that you know, quality groups, GPs, practitioners can talk to their patients about these issues in a sort of a structured way, rather than, you know, what I think might happen is that they come up as they become topical and hot, and in a more structured way. So I don't know, maybe something, Susan, from the patient participation element of the CCG, to suggest something that maybe we could then have a conversation and work on together might be useful. I don't know. I
think what you're connecting is that none of these work streams that we talk about are in isolation, aren't they? And actually, you're quite right. It was something that triggered in my mind when I was thinking, oh, I need to talk to Jill Mullally, who's the head of engagement, to talk about, well, what tools are we providing people so that we can have more involvement? Because at the moment we are slightly preoccupied with testing out communication, dealing with the crisis, making people feel secure, rather than embedding a behaviour and a partnership with patients and the public in terms of how health is delivered. The whole patient experience is being tested, but that's also useful feedback as well, isn't it? So it's about the involvement and the participation, but also connecting locally. The GP practices had patient participation groups, and I imagine during COVID some of that lay a little dormant. So it's about how we might sort of encourage that connectivity to happen as well, that makes meaningful sense to both parties, as well as the direct participation of individuals. So yes, I think outside this meeting that's a helpful connection to make. And you've also made the connection in terms of the other work streams that are going on, how recovery process or the transformational programs need to just make sure that we're connecting. And I think QPOC is exactly the right place to take things which are wider than primary care, but primary care have a key role to play. So that would be helpful outside the meeting, Andy, when we're thinking about what goes to QPOC from this committee. We perhaps take those issues that need a conversation where it brings in all the sort of multi-stakeholder groups. That's very helpful. Okay.
Can I also comment on Les's question about SIs and how that works in the system? And I would say, Les, probably, so the answer will be in a variety of ways, depending on the SIs, I think. So now, I don't know the detail of how this happens in individual boroughs or LDUs, but I know that in Wandsworth and Merton LDU, we report local SIs at our borough committee, which is currently still, you know, functioning, even if it has different delegated responsibilities at the moment. So we would always flag issues there, and from that would come, you know, whatever was needed in terms of if it was a purely acute issue, then that's fine. We deal with it in that facing direction. But where there's something, you know, that primary care needs to be involved with, or some learning for primary care, then that's probably where that would come from. Also, the quality teams in each borough or LDU do, you know, their root cause analyses that they oversee, and especially if it's a primary care SI, then it's that there are ways of learning through local communications, through the practice variation visits. You know, we had one issue which goes through our prescribing incentive scheme, for example, now to make sure that the learning is then embedded in our systems. So I think the answer is in a whole variety of ways, and there can't be just one way.
Yeah.
But it might be a good thing for a deep dive to kind of just look in the system generally at QPOC actually to see how that looks at some point.
I think with the MKAD thing as well, because it all sort of links together. I think, as Lucy said earlier, it's taking it as the broader how everything interlinks, and there are going to be more issues where one provider and primary care interact, and it's learning from those as a whole.
Yeah.
Thanks, Nicola.
Yeah.
Okay, thank you. John, did you have a question you wanted to ask?
Yes, I do. I was going to raise a couple of things, reflecting on some of the things that Nicola just said. One was the possible role of PPGs and others in the broader network to feed into the patient and public experience voice. In Richmond, we started to have a little bit of a look at that. We're not quite sure actually locally where to go with that, but we recognise that there is a role for PPGs who are so directly relating to particular practices to feed up their experience and knowledge through the broader system. So that was that point. It's also really heartening to hear that the issues around the workforce are going to be added to the quality discussions. And I wanted to raise separately one of the issues that's burning at the moment, of course, which is the impact of virus and the testing situation on the workforce and the risks that are around that and what the mitigations might be. So that's a very topical issue around the workforce and its preparedness for dealing with keeping on providing care while the virus is potentially having such an impact, giving testing, but that it should be added more generally to the consideration. So that's really welcome.
Okay, thank you. Jonathan, as have your points and your questions been responded to adequately, or did you want to come back on anything?
No, I think that was really helpful. So thank you, Nicola and colleagues, for the feedback. I suppose just one observation. It's sort of more a formal governance point than anything. Just on QPOC and the role of this committee. So obviously the Quality and Performance Oversight Committee has a pivotal role in knitting things together across different care settings. It's just in a formal sense, just to remind us all, and I'm sure people know this, but just to remind us that because of the membership of that committee, the formal responsibility for primary care quality continues to sit in this setting, which is why Nicola's presenting what she's presenting to this committee today. So I thought that was just important to clarify that there is a distinction between those two roles in a formal sense. But to Leslie's and other people's point, of course, we need to knit them together. And that's a conversation I had with Pippa Barber as chair of QPOC when we were thinking about how we're going to establish the new CCG. So I think that's a really important role for that group too. Okay, but yes, I think people have answered the question in answer to your question.
Okay. So given that, which I think is really, really important, Jonathan. So QPOC will knit all of this together and flag it. That's a critical role. But actually, having assurance about the quality of primary care, general practice services, sits here, and therefore I think whilst we've described the approach today, actually we need to understand what this committee needs on a regular basis to be assured, and that I think you need to give us a steer towards that so that then we can work through what that will look like and start to bring that and these things always take quite a lot of iteration, don't they? But we need to start doing that really.
Okay, Mark, did you want to make a comment?
It was just to reiterate that as well. I just think that if the responsibility for primary care quality sits with this group, then there should be a quality section regularly on this group that is prioritising and focusing on whatever the group decides to look at. So it's about having a regular session on quality at this group.
Can I just comment on that, because Andrew, I don't know, you're probably going to say this, but with your suggestion on the deep dives, I think is really helpful, because this is the right place to do that. But maybe also having a regular, I don't know whether the dashboard model that that's emerging is something that could be made at a South West London level. Is that what? Perhaps I'm taking words out of your mouth. I don't know.
So absolutely, certainly it can be. I think picking up on Mark's suggestion, early suggestions, what we'll do for future meeting is the PCMG highlight reports to have a quality section in there. So actually we've kind of got that consistency in what's going on locally, but make sure that it brings it back to a sort of a South West London narrative as we've described in the slides. And just to echo Jonathan's point, obviously if there are any specific contractual matters around quality, then obviously that will come here to be dealt with from a contractual angle. But I think it's really, it's really supportive. It's really great, all the work that the local teams are doing on this, because actually we could just take a step back and say, right, well, we'll just simply go down the contractual approach. But I think that would be entirely the wrong approach, because as a membership organisation, wanted to really work with our practice to really drive the quality every single day and really supporting that work with them as well. So I think we're definitely going along the right lines. There's an awful lot of a few moving pieces that we need to tie together, but I think the conversations that we're constantly having are certainly helping us get into that better position, that's for sure.
But from an assurance point of view, if you're developing a dashboard, even though it's only a snapshot, an indication of quality measures, quantitative measures, it would be helpful to have something come regularly if once they've developed, that we've got a South West London picture of the high risk areas, particularly perhaps the exception reporting of where the vulnerabilities sit, as well as not necessarily for lots of discussion, but just to keep us cited, and then to have a programme of deep dives around both the infrastructure that's going in and how we're tackling perhaps some of the sort of key risks that sit within.
Yeah, shall we have the sort of the deep dive next time on the sort of the workforce, the resilience, so the wider issues that we talked about today, and we can start to include.
Well, outside the meeting, we'll have a chat, and if people want to then feed back to you about how we might do that. But as you say, it's emerging, isn't it? And it sounds like it's developing anyway in terms of the framework that you've put together, Nicola, with colleagues. So as that emerges, thinking about what would be helpful to come here from your perspective as well, and if you're going to be producing data, whether that aggregate position on the South West London would be helpful. But Jonathan, you wanted to add?
Yeah, so I think that there is also a quality and performance work stream focused around recovery too, that Pippa is involved in, and Patrick and Andrew are also members of that group. I wonder whether there is some sort of actions for next time around perhaps meeting with Andrew and Nicola and members of the committee outside, just to talk about the quality dashboard and what we would like to see in that, and maybe we could get to a place of at least seeing a draft that we could share more widely with people when the committee next meets, because to Nicola's point, it is a really important role that this committee has in ensuring itself around primary care quality, and I think we could do with a bit of work outside of here, and then some of that played back to here to test, do we think we're doing the best we can to understand that across the nearly 200 practices that are in South West London CCG.
Yeah, thank you. That's very helpful. Have we completed that, Nicola? Do you think we've covered all the points? Everybody else happy with the questions? Was that a helpful feedback to you, Nicola?
Yeah,
and team?
that's really helpful. Just thanks to Andy and his team for the slides, because of course I didn't do those. But there's lots of comments there for us to take forward and establish a really good system so that this committee gets what it needs to have oversight. So thank you all for your comments, really helpful.
Okay, great. So if we move on to the next item, which is the Borough Primary Care Management Group reports. Now they're here to note, however, happy if any of the leads for each of those areas wanted to give it any sort of oversight. You don't need to go through it all. Assume you've all read it, but if there's any points that you want to raise specifically, then that would be helpful. Shall we go round Sutton, whoever is going to speak for Sutton?
Hello.
Hello. Hello.
That is me.
That's
Took me by surprise going Sutton first.
I know. I thought I'd just keep you all on your toes. You see. So.
Yeah. So at our management group, we've obviously done a lot of work with our primary care network. So they confirmed their membership. We've had one change of clinical director. We've got, and the replacement clinical director is another nurse. So we're very pleased that we've now got 2 nurse clinical directors in Sutton. We've been building on work that's happened through COVID. for integrated community response teams, and looking at how we develop those to deliver MDTs, both for complex patients in the community, but also for the MDTs for care home residents, including learning disability homes. Our clinical directors are really keen to work with our patient population, so that they're going to our patient reference group meeting this evening to talk to the patients both about how primary care networks have developed so far, but also to get some feedback from our patient group around how they could better engage with their population going forward. And then we've been working with the PCNs around development of the social prescribing model as we've sort of come out of the first phase of the pandemic, and also workforce planning to make sure that we make best use of the opportunities through the additional role reimbursement scheme. And then another couple of things. So we've been working really hard with colleagues across the system to improve the sort of experience around St Heliers A&E front door. So redesigning, sort of trying to make those patient flows much better, and ensure that patients are going to their GP when that's appropriate, or accessing GP services. But equally, you know, to have that much more integrated approach across 111, A&E and primary care, and access for patients into self-care. And then flu planning. I think every meeting at the moment to do primary care is mentioning flu. That those flu clinics have started now. There's been a huge amount of work done to across all practices who are really engaged with trying to make sure that we can vaccinate as much of our population, and that we can do it as quickly as possible as well, so that it's done, and that we're not trying to vaccinate people in the depths of winter, or if there's a second wave of COVID infections. And we've had some really positive feedback already from practices using barcode scanning for flu clinics, and actually about how that's really improved the throughput in the clinics, and made the flow really quick, and made the face-to-face contact time with patients much shorter, which you know, is what we're trying to do really while we're still dealing with a COVID environment.
Okay.
So yeah, busy times.
Croydon, Mark, are you doing Croydon's?
Yeah, so I'm doing Croydon. So
just a few highlights would be helpful, thanks.
So just to say, quite a lot of the meeting was kind of focused on the conversation that we've just had here at the Primary Care Commissioning Committee around quality. Croydon do have a dashboard, and it's probably slightly ahead of some of the other boroughs, and that's not me boasting. I think it's been developed there. So we have been using that. A word of caution is, because of COVID, quite a lot of the data needs some work, and so we're kind of doing a bit of a catch up with the data. But we are doing deep dives around things like SMI, immunisations and learning disabilities, a lot that is covered in the phase 3 requirements of the letter that was sent to practices. Just to say, there needs to be a big focus on inequalities, particularly I think in all boroughs, but particularly in Croydon as well. So that needs to be fed through all our work. And just picking up on Sean's comments about flu, we were also discussing that just over half of our practices have signed up to a kind of a drive-through flu vaccination in the IKEA car park, which is clinically safe, and I can assure you all a lot of work has been done, but about half of our practices are now signed up to that being an alternative and complementary to what they're doing at a practice level as well. It doesn't replace, it's in addition to what people are doing practice-wise. So that's probably the two things that I would mention from the meeting.
Thank you very much. Wandsworth and Cathy, do you want to give us any key points you want to raise?
Thank you. I think broadly the conversations have probably been along the same lines as in Sutton and in Croydon. So we've been talking a lot about our PCNs and about their workforce plans for the coming year, and indeed how they're going to be ready to go live with the new specifications from October. We've also been talking about the restart of local enhanced services and flu planning as well. Like all the others, it's a hot topic at the moment, and making sure that our practices have the capacity and capability to run a much larger campaign this year. The bit that's probably slightly different to the other boroughs is we've had a focus in each of the meetings around our practice variation approach. So this is different to our practice support team. This is a programme of visits that we do to each of our practices, specifically to talk about demand management. So we use them as a supportive approach to talk with practices about where they might be outliers in terms of the numbers of referrals they're making, their A&E attendances, their elective admissions, for example. And it's a clinically focused conversation about whether there is anything those practices can do differently in order to try and support the wider system to manage demand. Obviously, in the post-COVID world, some of the year-on-year measures that we might have previously relied on to have those conversations are no longer as relevant. And so we're tweaking the format of those meetings this year, very much to focus around the kind of the phase 3 recovery programme priorities. So as Mark's mentioned, around learning disability, around SMI health checks, and around things like use of kinesis as well, which is one of the key things, so that practices are ensuring they're making use of advice and guidance from consultants prior to referrals. So that was really a bulk of each of the meetings in Merton and Wandsworth, and we've agreed a plan for those meetings starting in October. So we'll be aiming to get around all of the practices before Christmas this year.
Okay, thank you. And Ahmed, do you want to cover Kingston and Richmond?
Thank you, Susan. Yes, so broadly very similar to some of the discussions in regards to flu and PCNs that were discussed in the other areas. But what I'd like to highlight from our PCNG are 3 contracting matters that we need to report back here for information and ratification, but also just for noting. So the first one is in relation to a remedial notice that was served to Seymour House Surgery in Richmond. This was served in by the previous Primary Care Committee in 2018-2019 in response to a Care Quality Commission report that found the practice to be requires improvement. Subsequent to that report being published, the CCG, the South West London contracting team and CQC have been working with the practice, and they've now been reassessed and been re-evaluated to be good overall across all 5 domains. So on that basis, the PCNG recommended that we lift the remedial notices that were in place from the previous Primary Care Committee. As the performance has improved, therefore they are no longer in breach of their regulatory requirements as per the contract. The second 2 contracting matters that I wanted to touch on are in regards to boundary changes. So the first boundary change relates to an application that was put in by Richmond Lock Surgery to extend a boundary into the northern part or the southern part of Hounslow, based on the footprint that they had previously had about 2 or 3 years ago, that they reduced due to practice sustainability issues. They've now applied to reapply to extend that boundary, apologies, back into the original footprint, but the PCNG took the decision not to approve that boundary as there was a area of the deprivation kind of excluded from that footprint, and it wasn't in line with the kind of historic grounds. So what we have asked the practice to do is to go back and reconsider and resubmit a new boundary application, which we will review at the next PCNG if they choose to. And then the third boundary contractual matter was in regards to a boundary change at Richmond Medical Group. This practice has recently undertaken a merger of 2 large practices in the Barnes and Sheen area of the borough. These practices merged. It was previously Sheen Lane, Jersey and North Road came together previously in December and merged contracts. The practice have now decided to, as they are under one contract, to revise that boundary to be aligned with the two previous footprints of the independent practices, and that covers the Barnes and Sheen area. We noted that this provided additional access to patients, and they were able to manage it based on growing capacity following the merger. So on that basis, in line with the SOP, we approved those that boundary change. And then finally, just one point I wanted to pick up, just because it was raised earlier by John from Health Watch. John, you mentioned that you weren't cited on where the kind of quality aspect was being managed in Richmond and Kingston. Just to confirm, we are managing quality in our PCMG. And I think you remember that we talked about the Care Quality Commission reports in the first meeting, and at the last meeting we touched on the GP patient survey that was recently published, and there will always be an item going forward. That's it from me, Susan. Thank you.
Okay, before we open up for questions, Andrew, could you just clarify then other points, the contractual issues that Ahmed mentioned? What do we need to be noting in this committee's minutes, please, and what do we need to agree?
Ahmed, just maybe because I know there's 3 different specific points, just maybe want to go over them very quickly, taking one by one, just because this is slightly different.
Yeah, sure. So, so as per the SOP, the only one that needs to be ratified by the Primary Care Committee is the first one in regards to lifting the remedial notice. So I would ask the committee to approve our recommendation to lift the remedial notice at Seymour House Surgery.
Okay, Les, your thoughts? Happy? Jonathan?
Yes, very happy, thank you.
William, you wanted to make a comment?
Yeah, thanks, Chair. So, actually, the board or the Primary Care Committee needs to approve all 3. So, as part of the delegation agreement, any boundary extensions or changes to it, we just need to ratify it as part of the delegation agreement.
Okay, so the first issue, then, I'm happy with to support the decision on lifting the breach notice. That's great. The second one was a boundary change, but as I understand it, there isn't a full proposal yet anyway, so that's just for noting at the moment because there's nothing to propose. You've rejected it and bringing it back. Is that right, Ahmed?
That's correct, Susan.
Okay, and then the third one around the boundary change for the extended.
The boundary change at Richmond Lock is the one that we approved locally that needs to be ratified here by the committee.
Jonathan, any issues?
No, I don't have any problems with it, so happy to support it. But Ahmed, could you say a little bit more about it, just so that the committee's heard a little bit more detail about that?
Yeah, sure. So, so the boundary that we approved, it was following a merger of 2 practices that we had in Richmond and Kingston. So one was Sheen Lane Surgery and one was North Road, and they both operated in close proximity to each other in the Barnes and Sheen region of the eastern part of the borough. So following the contractual merger of the North Roads of the 2 practices in October 2019, one of the practices that was previously operating, which was the North Road site, closed, and they moved into a new premises in Kew in a close location to Sheen Lane. So as these 2 practices previously had 2 separate contracts and 2 respective boundaries, what they have asked us to do and what they've submitted to us is a combination of those 2 boundaries put together, covering the entire footprint of the previous boundaries with a slight extension into the northern part of the borough where their new premises in Kew are now based. We were generally happy. Our judgment on this and our thinking was that this provides additional kind of access to patients across that borough, especially following a kind of a dispersal of a practice in Barnes that happened last year. So it provides patients with more access from that point of view. But we feel confident in respect of the footprint is is not something that we think will destabilise or be unmanageable by the practice, based on our kind of knowledge of their kind of their ability to deliver, but also it's not hugely different to what they were providing before. It's just come together now that they've got a single contract. Hopefully that's
does that help, Jonathan, in terms of
I think that's just really helpful, just to give us some further confidence, and thank you, Omid, that was really clear.
No
Happy to support.
So we're agreeing to ratify the decision that you've made around that boundary change. Sorry, John, you had your hand up. I just thought we needed to deal with those issues first. Was there anything you'd like to ask?
Absolutely. I just want to, I'm happy to acknowledge that Omid is quite right. I completely forgot we discussed CQC reports and other things out of PCMG, so I'm happy to acknowledge that.
Cheers, John.
On another point, we noticed that there's no patient survey results in the Croydon PCMG report, and we were wondering why that was.
Mark, did you want to? You're on mute, sorry.
Sorry, could you repeat the question?
Yes, we noticed that there was no patient survey results in the Croydon report, and we were just wondering why that was.
It was just an oversight in the planning. It will be on the next agenda for Croydon.
You're just seeing a snapshot in time, John, of the agendas and the work plans of each of the local boroughs. Okay, great. Right, well, thank you very much for that. It's very comprehensive and very helpful, all of you, to get some insight into the issues that you're addressing. I'm going to move on. We haven't had any public questions by email, as far as I'm aware, and therefore just need to check if there's any other business. Les, have you got any other business? And Jonathan?
Nothing from me, Susan.
And Andrew, is there anything else that we've last minute?
No, thank you, no.
Okay. Does anybody want to make any last points? If not, then I'd like to thank you all for your time and wish you a good morning, and look forward to seeing those who are needed at the Part 2 meeting in a little while. In fact, actually, can I just check, we're due to meet for Part 2 at 11:45, is that right, or 11:30?
Yeah, 11:35, yeah.
Is there any chance perhaps we could bring that forward? People are available. Perhaps we could meet at about 11:15 time for. That would be helpful. Okay, thank you very much. And the next meeting, have we got a date for the next meeting?
We have, it's November the 18th in the morning.
In the morning. Okay, well, thank you very much, and look forward to seeing you then. Bye-bye.
Thank you.
Thank you.
Thanks, Susan. Bye.
Thanks, Susan.